I want to start with thanking Helen and AMMF for inviting me for this to join you all today. And also, I would like to take this opportunity to commend and congratulate the extraordinary work done by Helen and AMMF in raising awareness, in promoting science, and helping patients with this unfortunate diagnosis. And extraordinary is probably falls short of what Helen and AMMF have done over the years. Well done. And so I'll share where we are with cholangiocarcinoma and transplantation, give a bit of background from experience in other parts of the world, and then finally end up with giving you a current update on where we are in UK. So when transplantation started in late 60s and early 70s, some of you may be aware, liver cancer was one of the indications for transplantation at that time, including cholangiocarcinoma. But soon it became apparent that the outcomes were very dismal, so that became a contraindication and remained a contraindication for a long time until some of the pioneering work done by centers like Mayo Clinic has rejuvenated the role of transplantation for cholangiocarcinoma. And for the sake of clarity, I just want to reinforce again, within this broad term of cholangiocarcinoma, there are so many subtypes with different outcomes. So transplantation, there is now some experience in all of these areas, including small cancers with background chronic liver disease, large intrahepatic cholangiocarcinomas with background normal liver, unresectable tumors, then perihylar cholangiocarcinomas with background primary sclerosing cholangitis, and then de novo cholangiocarcinoma without any background chronic liver disease. So moving on to what is the experience with perihylar cholangiocarcinoma and intrahepatic cholangiocarcinoma, and no discussion of transplantation for cholangiocarcinoma can happen without mentioning Mayo Clinic and Mayo Protocol. And some of the key reason for success of this protocol and the experience from Mayo Clinic are the strict selection criteria. And some of the interesting points in the selection criteria are that they selected patients with small tumors where there is no evidence of spread to the lymph nodes or spread anywhere else in the abdomen or in the body. But also something slightly controversial is that the need for a cytology or a positive histology, it wasn't essential for the diagnosis of cholangiocarcinoma. They have used other criteria that would support the diagnosis of cholangiocarcinoma. And all these patients then had some form of laparoscopy or a laparotomy to make sure that there is no spread elsewhere. And another key component of Mayo Protocol is neoadjuvant therapy with external beam radiotherapy and concurrent chemotherapy. Probably the weakest bit in this is probably brachytherapy, but I'm not an expert. Maria and colleagues here would probably correct me. And then they all received chemotherapy until they had the transplant. So over 25 years, 376 patients were enrolled in their protocol. Whilst majority were patients with background PSC, a significant percentage of late were de novo hilar cholangiocarcinoma. What is interesting is that as the treatment progressed, 1 in 7 patients dropped out because of disease progression. And once the treatment was completed, the neoadjuvant treatment, when they had laparoscopy or laparotomy, again, a significant percentage were removed from the protocol because of evidence of spread to lymph nodes or metastasis. So all in all, about nearly 2/3 of patients finally underwent transplantation. And what is interesting and what is encouraging is that even on an intention to treat analysis, the 5-year survival in these 300 plus patients is about 51%. And if you look at those who actually underwent transplant, the 5-year survival is excellent at nearly 70%. And then this is the interesting comparison. Patients who had background PSC and patients with de novo hilar cholangiocarcinoma. And what is interesting is that despite the perception that patients with PSC has probably more adverse biology, they did the best, both on an intention to treat analysis and on an actual analysis of those who had transplant. So they did better than de novo hilar cholangiocarcinomas. And similarly, the recurrence rates were also higher in patients with de novo hilar cholangiocarcinoma. So quickly summarizing, what is the current status of transplant for perihylar cholangiocarcinoma? Transplantation is offered in North America, in our neighboring country Ireland, and many Western European centers, either as standard of care or as a service evaluation. And most of these programs use neoadjuvant therapy, but what is interesting is that countries like Netherlands, they do not use any neoadjuvant therapy, but they have the same strict selection criteria. And what is clear is that in patients with background PSC, you have good outcomes in selected patients. Far more controversial, I still believe, is the role of transplantation with de novo cholangiocarcinoma, and I think this needs much more careful evaluation with clinical trials. But I believe in the United States, it's becoming, again, a standard of care for even de novo tumors. Moving further to intra-hepatic cholangiocarcinoma, a fairly similar story. Until some of the multi-center studies, starting with the study in 2014 by Sapusochin, it was a multi-center Spanish study, I think, if I remember correctly. So their study actually laid grounds for reconsidering the role for transplantation with the intra-hepatic cholangiocarcinoma. So they've showed, and again, I want to stress that most of these patients, the diagnosis of intrahepatic cholangiocarcinoma was made after the transplant when the liver was examined pathologically. So these were all incidental tumors, not done with the purpose of transplanting these patients. So their survival was surprisingly better than what everyone thought at that time. And then there were further studies, and finally, the international multi-center study by the same author and with much wider collaboration, they showed that in selected group of patients with intrahepatic cholangiocarcinoma, and they call them very early, which is tumors less than 2 centimeters in size, you get excellent outcomes. 5 years survival of 60+%, which is probably comparable, almost comparable to transplantation for hepatocellular cancer within Milan criteria. And this is the particular paper I'm mentioning. So again, the recurrence rates and survival are far better if the tumor is single and less than 2 centimeters in size. So that made the rest of the world start thinking. And this is, again, a further extension of that idea. And this is a French multi-center study which came about 3 years back, looking at the role of resection and transplantation in patients with intrahepatic cholangiocarcinoma with cirrhosis. And what is interesting is that even though the overall survival for resection and transplantation are similar, but the disease-free survival was far better with transplantation. And then they looked at this, the size of the tumor, less than 2 centimeters versus 2 to 5 centimeters, and tried to look at is actually the larger tumor doing worse. And interestingly, the overall survival is similar and the disease-free survival is similar. And their conclusion from their study is that probably we should be thinking not just less than 2, but 2 to 5 centimeters, as long as they are well-differentiated tumors with good tumor biology. So it's again pushing the idea of transplantation in a wider group of patients. So that's in patients with background liver disease. And then this is, I apologize for the typo, it's actually a paper from 2011. This is from the Los Angeles group. And at that time, many of us thought this is actually crazy what they're doing. So unresectable large intrahepatic cholangiocarcinomas, they looked at the survival with resection and transplantation, but transplantation involved giving them chemotherapy beforehand and chemotherapy afterwards. And surprisingly, the results for transplantation were comparable and probably, one could argue, better than resection. And then they looked at can we identify risk factors which allow us to stratify? And the usual culprits came as the risk factors: the number, the pattern of spread, the growth along the nerves and the blood vessels, and background PSC, and no neoadjuvant therapy. So then they stratified and looked at if these risk factors were not present, what is the outcome for transplantation? And surprisingly, it was very good. So as long as they had some chemotherapy before and after, some systemic therapy, and if they didn't have risk factors, you had excellent outcomes. But these were all small numbers. But that idea obviously caught on with further evidence that came with the cirrhosis and intrahepatic cholangiocarcinoma story. And this is a pilot study published, I think, 2019 or 20, from MD Anderson and their partner Transplant Institute Methodist. So they had a very clear protocol, neoadjuvant therapy with different lines of therapy. And 6 patients finally went through for transplantation. The numbers are small, but it is a beginning and encouraging results. So what it gives us the hope is that as systemic therapies improve and get better than what they are now, I think there is a potential role even for larger tumors in replacing the liver to gain long-term survival benefit and hope. So in summary, with intrahepatic cholangiocarcinoma, the small tumors, I think the results are very good if they have background chronic liver disease, as good as HCC within Milan criteria with transplant. The challenge is, how do you diagnose them? Biopsying such small tumors is not easy. So that is a challenge. It's currently offered as transplantation is offered as a service evaluation in selected centers in North America and in Europe of varying sizes. So where are we now in UK? So this is our paper from Leeds way back in 2008. We probably the only published experience from UK on transplantation and resection, and this experience was gathered before we became very strict in UK, and cholangio was an absolute contraindication. But even at that stage, it told us that you can get survival for a few years, but ultimately without any clear selection, strict selection, and lack of neoadjuvant therapy, unfortunately, no one lived beyond 5.5 years. But there was hope even at that time. And recently we collected the data from all the 7 centers, about 95 patients. And you can imagine there are a lot of challenges in interpreting this data, being retrospective from multiple centers. But a similar number of intrahepatic and perihylar cholangiocarcinomas. And what is interesting is that even in this unselected group without any neoadjuvant therapy or adjuvant therapy, the survival is not completely dismal. The 5-year survival with intrahepatic is actually 57%. And again, I would caution about interpreting the pathological staging of such a retrospective data from so many centers. But what is clear is that small tumors, without any other treatment, you can still get very good survival with transplantation. So it once again emphasizes the importance of selection, and the same data in a different way. So NHSBT and the Liver Advisory Group wanted to put together a protocol for service evaluation, and the group was developed with representations from across various sections of the society. And the patients who this service evaluation would include are patients with very early intrahepatic cholangiocarcinoma and patients with perihylar cholangiocarcinoma with background PSC. So very early, I've already said what it means, and the group of patients we would include are patients where resection is precluded from poor liver functions or the position of the tumor. Mixed tumors will not be included in the service evaluation. And the final recommendation of the group is that if we have difficulty in recruiting patients and the numbers are not we are not having the numbers which we are seeking to recruit, we are willing to, or we recommended an extension of these criteria to 2 to 5 centimeters tumors, provided they're well differentiated tumors. So the pathway for these patients, we hope, is going to be very straightforward. referral to the transplant program and going through the cancer MDTs, transplant MDTs. A key factor which the advisory group is very keen to put in place is that transplantation will be executed within a short period of time, and for patients in service evaluation, we did not want these patients to be waiting for a long time, and so allocation systems are being changed to make sure when the service evaluation is active, patients will get transplanted in a reasonable period of time. This is obviously much more challenging, PSC and perihylar cholangiocarcinoma. A key difference from Mayo protocol is that our service evaluation mandates a positive histology or a cytology, and that would mean a slightly more aggressive endoscopic assessment of these tumors, and the usual exclusion criteria, which includes any previous attempts at resection of these tumors and cancers within the last 5 years. Very standard radiological assessment, nothing different from what resection programs do, but a lot of emphasis on re-imaging after neoadjuvant therapy, and if a patient happens to wait more than 3 months, further evaluation again. So endoscopic assessment is a bit more complicated, more challenging because of the need to get positive tissue diagnosis, and so it needs a lot of collaboration between the referring unit and the transplant centers to make sure that appropriate endoscopic assessment has been done to get the positive diagnosis. And the most innovative part of the service evaluation and the protocol is using proton beam therapy in place of external beam radiotherapy and brachytherapy. So the group has been very ambitious in recommending proton beam therapy because of the belief that it has several advantages over the conventional radiotherapy options in the Mayo protocol, and then the standard chemotherapy regime. But being ambitious and recommending something very innovative, it comes with its own challenges, and these are some of the things which we are trying to circumvent now. So once the treatment is completed, again a very similar pathway as Mayo, reassessment with a laparoscopy, and if there's no evidence of spread, transplantation, preferably within 3 months of listing. So very complicated path, but I think once the program is live, we are going to have a lot of events to communicate the pathway, and also in a service evaluation like this with such innovative treatment, data collection and data management is very important. So we recommended the formation of an advisory panel which has multiple roles to facilitate this service evaluation and also to monitor adverse events of special interest. Thank you, Yvonne, for sharing the term. Thank you. So the service evaluation will recommended that we should recruit 30 patients over 3 years. Currently at the stage of discussions with commissioners around proton beam therapy, and part of those discussions include putting together a data management group too. So I happen to chair that committee, but this was actually, I want to acknowledge and thank everyone in the committee, which was truly a multi-center, multidisciplinary group drawn from all sections of the society. And my special thanks once again to Helen and Martin Wormsley, who have provided a very important voice for patients who suffer from this unfortunate diagnosis, and also to Nigel Heaton, consultant surgeon from King's, who has done a lot of background work before he passed on this work to us. So with that, and I'll end with this. This is actually Tom Starzl, who most people consider the father of modern day transplantation and definitely of liver transplantation. What he said, it's interesting. It applies to every, not just to transplantation, but to life in general. So I thought it's apt to end with this. Thank you.
Thank you very much, Raj.